the next speaker in this session on the hemoglobinopathies in obstetric ICU, Dr. Sita Lakshmi.
So the topic that has been given to me is hemoglobinopathies in obstetric ICU. And I must thank Madam Dr. Malini, the previous speaker, who spoke a lot of what I wanted to. And I realized since there is a lot of continuity between what she said and what I'm going to be saying, it has made a lot of my job much easier. So when we talk about hemoglobinopathies, all of us know that these are inherited disorders. What comes to our mind is three broad groups. One is a structural defect in hemoglobin. The commonest example that we can think of is sickle cell anemia. The other is a decreased production of normal hemoglobin. The commonest example that we can think of is thalassemia-related syndromes. Another uncommon condition that we should keep in mind is what is referred to as hereditary persistence of fetal hemoglobin. Very, very uncommon. One may rarely encounter in clinical practice. Now, we should know the magnitude of this problem, and the very fact that it has been included for discussion in this conference highlights the magnitude of the problem. We all know it's a genetic defect, occurs worldwide, associated with significant morbidity and mortality, and is present in our own country. And with a lot of population migration, we see a lot of them in Bengaluru. We have patients from northeastern parts of our country. We have patients from Punjab and other places. And therefore, the chances of us encountering these cases is very high. And another important aspect that we should keep in mind is that the phenotypic spectrum of this disorder is very, very varied. At one end, you have death in utero occurring because of conditions that are well known to us called hydrops fetalis. At the other end, you have patients who are asymptomatic, who are not even diagnosed even in an adult age, and they come to us for the first time when they are pregnant and with anemia. So that is the nature of the problem. The spectrum is very, very varied. There are enough of testing facilities available, but one should keep in mind antenatal screening is very important, and we should be able to know which are those cases which require screening. Coming to the laboratory perspective, there are barriers that exist to provide accurate, timely, cost-effective service for antenatal detection. This includes, because as I said, late presentation and booking of these cases, availability of patient's family members, patient's partner for screening, lack of enough information about ethnicity, lack of adequate obstetric history, especially we people sitting in our labs, we don't get much history, so it can become a challenge at times. Difficulties in communicating between the coordinating groups can also be a problem. And very many times, these patients go to different hospitals with anemia, get a lot of blood transfusions, which masks the picture. So diagnosis can become very, very challenging. Prenatal diagnosis would be the best if possible, and I'm not going to focus on this aspect. And of course, antenatal screening can play an important role. Now, when we talk about screening tests, these tests, as I mentioned, are easily available in most labs these days. One important screening test is hemoglobin electrophoresis. Another test is called high-performance liquid chromatography. They can be done very simple tests, very easily interpretable, and technology is there today. But the challenge is that the patient's picture can be masked due to previous blood transfusions can pose a diagnostic challenge. So this is HPLC, and what I showed you earlier is a hemoglobin electrophoresis. Okay, so coming to, I'll just focus a little bit on thalassemia and then move on to sickle cell anemias. So we all know the diagnosis of thalassemia can be based on a simple peripheral blood picture if interpreted in the right manner, given the right clinical conditions. But as I said, there are several features that can mask the blood picture. And pregnancy in thalassemia major is high risk, and that is why we are discussing this topic today. And gestation can actually be very safe for both the mother and the fetus as long as we have already diagnosed this condition in very early pregnancy, and there is close monitoring and in conjunction with an expert who is dealing with, who is used to managing thalassemia patients. Now, as I mentioned, thalassemia, there is a wide spectrum. So if we talk about thalassemia trait or thalassemia minor, these patients can have very mild anemia and therefore may not really complicate the outcome of pregnancy. Parenteral iron should be preferably avoided. Just oral hematinic supplementation should suffice to maintain their optimum hemoglobin levels. So if you look at the guidelines, actually it's recommended that about hemoglobin of 8 to 9 gram per deciliter is good to maintain for these patients because of the added stress of pregnancy. However, one may have to resort to transfusion when these patients' hemoglobin is below the expected hemoglobin of 8 and definitely before 7. We all know the risks associated with transfusion. There are both immediate as well as delayed risks, which ma'am has explained very nicely, and I'm not going to be able to touch upon all those aspects again. Now, there are complications of thalassemia in pregnancy. So, thalassemia in conjunction with gestational anemia that is expected to be there in pregnancy complicates the picture. So this can cause fetal intrauterine growth retardation and preterm labor, well known to this audience, and I don't have to speak much about it. Therefore, as I mentioned earlier, most centers prefer to maintain a hemoglobin of at least 8 to 9, although optimum is said to be 10, to ensure that there is appropriate fetal growth. Now, despite this approach, we all know very well IUGR is common, and therefore there are other complicating factors which contributes to the anemia in pregnancy. And very importantly, in those patients who are previously transfused, they get sensitized to different donor red cells, develop antibodies, which are red cell alloantibodies, and sometimes complicated by autoantibodies, posing a major challenge to transfusion. Now, if we look at thalassemia intermedia, which is not as severe as thalassemia major, some of them are minimally transfused, but there would be a few who have received repeated transfusions. In these situations, an extended genotype, antibody screening, and the choice of fully phenotype matched. Ma'am already said a complete extended RH phenotyping and KEL phenotyping will be ideal, although this can be difficult at times unless it's planned well in advance. Most centers may not be able to do an extended phenotype, so just an ABO and RH phenotype would probably suffice. Ma'am also spoke about viral transmission, the role of CMV virus. To get a CMV negative blood is almost impossible. Therefore, it is preferable that we use leukoreduced blood because we know that the CMV virus resides in the nucleus of the WBCs. So by eliminating WBCs by the process of leukoreduction, we are trying our best to minimize the risk of CMV infection. Okay. So there could be those patients whom have managed very well without any transfusion, have maintained a hemoglobin of 8 up until the later stages of pregnancy, and in such cases, it's advisable not to transfuse them, and maybe erythropoietin has a good role in these cases. As I mentioned, there are complications of transfusion. We are all extremely concerned about the auto and allo antibodies complicating these patients. As I mentioned, the rate of red cell allo immunization following a single unit of red cell is 1 to 1.6%. But in patients who have received repeated blood transfusions, it can be as high as 60%, posing a challenge to transfusion. And these allo antibodies cross the placenta, enter into the fetal circulation, resulting in a significant hemolysis in the newborn and contributing to anemia in the newborn. And therefore, managing these babies is another area of specialty by itself. Now, there are postpartum stage complications of thalassemia patients. They are prone to a hypercoagulable state with a high risk of thromboembolic episodes. Now, what are the mechanisms? Briefly, the presence of abnormal red cells which shed prothrombotic vesicles, contributing to formation of thrombus, a variety of alterations in platelet function, elevated levels of endothelial adhesion proteins, elevated levels of plasma clotting factors in pregnancy, low protein C and protein S all complicate the picture of thromboembolism in pregnancy, especially with thalassemia. Now, those who've had a splenectomy, the incidence of thrombosis is said to be higher. And with patients with venous thromboembolism, and there is associated organ dysfunction, especially in patients with cardiopulmonary abnormalities, liver function abnormalities, and contributing to the complication in these patients. So there is a role of thromboprophylaxis. It is said that low molecular weight heparin prophylaxis should be administered, followed by 7-day postpartum discharge regimen after a normal vaginal delivery, or a 6-week regimen after a cesarean section. Now moving on to other bigger challenge, that is sickle cell anemia. Diagnosis, we all remember as MBBS students, we have all seen sickle cells in the peripheral blood. This disorder, again, the spectrum is very varied. You have the minor forms, which is a heterozygous form sickle cell trait, and you have the major form, which is a sickle cell anemia. Now, this phenotype of sickle cell anemia can be challenging in pregnancy to manage because there are crises. There are what is called vaso-occlusive crisis that complicates pregnancy in these patients, and transfusion can be challenging. Now, when we talk about sickle cell anemia in pregnancy, infection, thromboembolic complications, vaso-occlusive crisis adds to the risk. And these patients, there are also pregnancy-related complications which can complicate the pregnancy, like preeclampsia, pregnancy-induced hypertension, and contribute to fetal morbidity and mortality. We all know the pathophysiology of sickle cell. The only point that I want to draw your attention to is the vaso-occlusive crisis, which is more known to occur with sickle cells and which does not seem to occur with thalassemia. And therefore, pregnancy with sickle cell anemia is a high-risk condition. As I mentioned, the trait form may not cause any problem in an uncomplicated pregnancy. The chances of these patients getting into sickling crisis very remote unless there is associated hypoxia or dehydration. So it's important for us to ensure that they avoid all factors which cause hypoxia and ensure hydration in these cases. Now, sickle cell trait in labor. One should remember that it's good to get a CBC done and keep cross-matched blood available, ensure good hydration and oxygenation to prevent the rare occurrence of sickle cell crisis. It's important to ensure that cord blood is tested for hemoglobinopathy as part of screening of the newborn and monitor for any evidence of crisis or infection. Now, during the postpartum period, there could be situations where one may need to transfuse blood. There may be a need for an exchange transfusion or top-up transfusion. The purpose of an exchange transfusion?
You have a minute
extra. Sure. The purpose of an exchange transfusion is to ensure that the HbS levels are less than 30%. As I said, HbS contributes to the crisis, and top-up transfusion is to maintain normal hemoglobin to ensure adequate oxygenation. So there are certain situations where top-up transfusion will play an important role, especially when patients have an aplastic crisis or just anemia complicating pregnancy. And as I said, hydration, oxygenation becomes an important part of management of these cases. Alloimmunization is something that we need to be worried about. And therefore, coming to conclude, since sickle cell anemia is a high risk when it associated pregnancy, and a multidisciplinary approach becomes very important, transfusion plays a critical role. I would just like to end by saying, by drawing your attention to those key messages. Hemoglobinopathies in pregnancy is high risk. Detection can be challenging. The role of transfusion is to maintain an optimum of hemoglobin of at least 8. Need to maintain an optimum hematocrit and HbS concentration in order to prevent crisis. The role of transfusion-associated risks like alloantibody development, risk of TTIs should be kept in mind. Important to do red cell extended phenotyping to provide appropriate compatible unit of blood. It's important to take adequate measures to prevent vaso-occlusive crisis. And of course, antenatal screening and prenatal diagnosis, prevention is better than cure. So screening and prenatal diagnosis is something that we all should aim at to ensure that we don't come across these cases in our practice, which is, I think, very far-fetched at this point of time. Thank you.